Well, hello, everybody. Welcome to IRG's Health Matter. This is our podcast and where we talk about everything health. And joining us today is Dr. Grant Garcia. He's an orthopedic specialist, specializing in orthopedic medicine and sports medicine. Dr. Garcia, how you doing?
I'm good. Thanks for having me on here. Looking forward to this.
Absolutely. We're glad you're here. Hey, before we get into kind of nitty gritty here, let's talk about kind of your background, your training, kind of your interest in orthopedics, but more importantly, orthopedics and your fellowship in sports medicine. Maybe you can describe kind of how you got to where you are today.
So went to Brown for undergrad, Penn for med school. Most of my training's on the East Coast. Then went to a place called Hospital Special Surgery, which is pretty large orthopedics hospital. That's where I did my residency. Got to train with a lot of professional sports teams there. And then moved on to fellowship at Rush University. And this is in Chicago with Brian Cole. So this is where it spurred my sort of innovative desire. And so we did the Bulls and the White Sox. And we just always got to experience different cutting edge procedures and cartilage restoration. So then when I came here, I tried to mimic that sort of fellowship that I had, and that's really what I've been able to do, and I really enjoy it and really be able to offer more cutting-edge procedures, but also do standard procedures, and we'll talk about one of those cutting-edge procedures today, I think.
Yeah, absolutely. We're going to, before we get to that procedure, I mean, I'm interested for our listeners to really understand as a orthopedic surgeon, and you talk about this 5-year residency and then 1 year of fellowship. You know, first of all, let's just back up. So you went to 4 years undergrad, and then you go 4 years of medical school, then you go 5 years of orthopedic training, and then you go 1 year of fellowship. Maybe describe that fellowship, because that seems to be a very popular term. We're seeing fellowship trained orthopedic surgeons and fellowship trained physicians a lot more in the world. Describe that fellowship. You talk about being at Rush in Chicago, but this is a 1 year specialization. Tell us about that. I mean, a little bit more in depth.
Yeah, this is really the game changer for the orthopedic surgeon when people are looking for them, especially if you're looking big city, you know, Seattle, LA, you name it. You learn a lot of the training you do, and I felt pretty good. I probably could do a majority of the things I do now if I had not done the fellowship. But that's really what kind of catapulted me into being that super specialist. And that's what I wanted to do. I wanted to be all sports medicine, take care of the toughest situations possible, but on top of that, be able to do them really well and have a plethora of surgeries. So going to I do about 100, 120 different sports surgeries. So it's not the standard bread and butter. And so in order to do that, you need to it's hard to get that volume. And it's hard to find the right patients to, be learning and continue to work and improve your skills. And so in fellowship, you have these guys that people fly in to see, and they see a volume higher than the average person in the country, significantly higher. And so as a result, we learn how to do these really complicated things and see them done really well by some of the best guys in the country. I mean, Rush, even now, is probably 1-2 in terms of sports fellowships in the whole country. So we're seeing the upper echelon of doctors who work there, and all the guys I worked with were top notch. And so it really is an opportunity for us to see that at a higher level. I mean, we do almost 1,000 surgeries that year, which is considered insane if you were in your own practice. And so that we get this extreme exposure in all different styles too. I mean, we work with 6 different surgeons, so we get to put them all together. It's essentially getting the best of everybody, and then you learn all that and you take it to your practice. And so that's what I was able to do.
Well, that's amazing. 1 year of this intense training from various people that you're studying under, the best in the country, the best maybe in some parts of the world. You took that 1 year of intense training, brought it to Seattle, and tell us about your current practice in Seattle. You practice there on 45th. You also, I think, have an office in Ballard, but maybe you could talk about your current practice. Let's talk about taking that fellowship training and then bringing it into your practice.
Yeah, so this is where it really helped me separate me in Seattle. So when I came here, there's a lot of great surgeons, and you always have to it's a very competitive market. But in Seattle, there was a little less of the sort of really high level cutting edge stuff, and especially really complicated. So I specialize in only sports, and I do whatever it takes to save the knee or save the shoulder or save the elbow. And so I do a lot of complex reconstructions. I specialize in revision surgery. So I see a lot of revision ACLs, saw a few this morning. But also one of my number one things that's just less commonly done is cartilage restoration. So what I do is I have a number of different procedures. And again, from the basic replacement of cartilage or MACI or other procedures you do, but then I know how to do all the other stuff on top of that, which is to realign the knee, to change the structures of the knee, and all these things you need to do if you're going to do a good job. And then continuing to learn new things. And so I really offer on the more complex side, which I like. Not every doctor likes doing the more complex stuff, but for me, that's really important. And I knew if I wanted to be a Seattle doctor that I was going to take on everything that showed up. And so generally, half the time I'm the fixer and half the time I get to take care of something primarily. But I love doing all that stuff. It's what gets me up in the morning. I like to challenge. So.
That's what it's all about. That's why I love being a physical therapist. Matter of fact, I started physical therapy so long ago. That's how old I am. That orthopedic surgeons, they did everything. Back in my day when I first came into the world of physical therapy, an orthopedic surgeon would do a spine. He would do a knee, shoulder, him or her. They did everything. Now they're specialized. It's come a long way. And we're going to talk about some advancements in medicine and surgical techniques. And one of them particularly is this anterior cruciate ligament and the repair or reconstruction of that. And you do this a lot. How many ACLs would you say in your practice today do you do a year? Just rough numbers.
It's so busy now. We do 3 or 4 a week, maybe 5. So it's probably over 100. I've become more in the city. I do shoulders and I do a lot of elbows. But for some reason, ACLs have exploded in my practice. People think I'm just the ACL guy. So I see a lot of ACLs. And again, it's all combinations.
Yeah, I know. You have a plethora of skill. I've worked with you and I've seen and I know some of the stuff you've done. It's amazing. But when we talk about the ACL, the anterior cruciate ligament, maybe we can talk about the anatomy of that ligament, of the knee joint, and why that ligament is so important. Maybe talk about the mechanism. How is it injured? And then we can dig into the treatment and maybe some of the advancements that have just maybe come along in the last 2, maybe 3 years. Again, medicine is changing, it seems like almost every day.
Mm-hmm. So the ACL itself is really important. It's called the anterior cruciate ligament. And it's what prevents the lower portion of the leg, the tibia, from shifting forward. And there's some other nuances to it as well. But you really need it for, inline motion is not as important. But if you want to do skiing, jiu-jitsu, rock climbing, you name anything that the Seattleites like to do, which I see frequently, or tennis, the ACL is really important. And what I had 2 people this morning that had ACL tears. I talked about potential surgery. It's not just fixing the ACL. That's a very simplified version, but really what it is to protect the other parts of the knee. You come in with an ACL tear, and if you are not a coper or not able to handle and your knee slips out of place, you can damage the secondary stabilizers, which are your meniscus and your cartilage. Mm-hmm. And as a surgeon who does cartilage and meniscus work, I see a lot of people that have had this problem and waited longer. And so that's when I say, listen, I get to see the worst and I get to see the best, and I want to keep you in the best category.
Okay, so if someone has an ACL injury, this injury is usually sustained with a lot of times it's not contact, it's deceleration or it's a change of direction. Someone comes in. Most people when this happens, they hear a pop, they have some immediate swelling, maybe lack of stability. What are you seeing when someone walks in? How are you diagnosing it? And then today, in today's world, with all the advancements and your training, what are you doing to repair it? Let's talk about that.
Yeah. So first part of your question, in terms of injury, you see it from soccer. Skiing right now is big. The ski season comes, all of a sudden the office gets really busy.
Yeah.
We have ski season. So but also, one person I just talked to, he was skiing and he popped it, not even on a big turn. And so sometimes it's just that quick deceleration, or you see a lot of non-contact ACLs. We've seen them in the NFL. We've seen them in general. There's different reasons for that, but it's just that deceleration with a twist. Enough to bring you to the ACL tear. And then in terms of options, the thing now is it's almost like I call myself like I've got a Rolodex of options for you. So patients come in, they may have seen someone that doesn't do as many different ACL options, but they come into my office and I'm saying, okay, here are 7 options. And they're like, holy cow, I was only told there was 1. Wow. I'm like, no, there's 7 options or 6 options. There's different graft types. There's how we can fix it. And then the stuff that people really want to know about, which is repairing it. So the interesting part here is that the word repair is thrown out too many times. We've talked about athletes. If you read people's online, someone will say, okay, this person had their ACL repaired, but most of the time they didn't actually have it repaired. They had it reconstructed. But the problem is that doctors and even anybody online, they use the word repair and reconstruction interchangeably, but that's not accurate. especially now that we have potential tools to repair some people's ACLs. Like we talked about, I mean, we mentioned some NFL players. When it says they had an ACL repaired, they probably didn't have it repaired. They had it reconstructed. And so that's one important thing for the listeners to hear is the terminology. Reconstruction means we use some other piece of tissue, either their own or from a cadaver, and then we remake the ACL, which is what most commonly done.
Mm-hmm.
And then there's the repair side of things. And that's when we actually are able to fix that ACL ligament tissue and get that patient back as well.
Well, let's talk about that, because that seems like that is a fairly advanced surgical technique and probably just came on the scene. How long has this actual repair been going on that you can actually repair that ligament? Go ahead.
This may blow your mind a little bit. So the idea of ACL repair has been around for a long time, but the problem is that the older techniques we had did not do very well. And so it's got a bad rap. So when you have people that didn't specialize in just sports surgeries and they did all these around, they'll say, oh, ACL repair, we don't do that anymore. That didn't do very well. Well, the answer is we have newer technology and we know new things now. Not everybody can get it. Everybody is ineligible for this type of procedure. And then there's actually two types of ACL repairs. The one we can talk about, which is the bare ACL, but there's also another type of ACL repair that we do as well. So it kind of blows people's minds to know that I have so many different options.
Yeah.
And so over the last 2 or 3 years, there's been 2 procedures that have come out to help fix ACLs. The first one is the one we'll talk about, which is the sexy one you've seen in the news, called the bare implant, bridge enhanced ACL repair. And what this is, was designed about 10 years ago from one of the doctors at Harvard. And what they found is that, like, if you may know, or you may have talked about in your shows, MCL tears.
Yep.
So when MCL tears, the MCL heals really quickly and almost never needs surgery. So what they found is they're like, let's turn an ACL into an MCL. And so what they do is there's this collagen that's the collagen proprietary they designed. They fill it with blood, and then you actually, there's a technique, you slide it in and you put it right next to where the ACL that's been repaired is, and you can turn this blood clot into some healing factors with the collagen and get the ACL to heal. And so that's the idea. And there's been now a number of studies. It started on clinical trials. It's gone through, like I said, 8 years of rigorous testing. I think the oldest patient now is like 9 years out, and then was clinically offered about 1.5 years ago. It passed FDA approval and is in clinical trial, and now works with one of the companies that purchased the implant. And so the data's been pretty interesting on it. I think there's obviously still some new things on there, but this procedure has a way to save the certain patients that have certain ACL tears and get them back to the sports that they like. Understanding, obviously, there's risks and benefits of the procedure.
Well, who qualifies for this? Because as I'm listening to this is amazing stuff, because I've always I've been out of the clinic a little while. So when I used to rehab ACLs, they were all done pretty much bone, tendon, bone, or a hamstring tendon was used. Very few people that I know in the area did actually what you're defining as a repair. Yeah. And so you're doing these things right now. But I've got a ton of questions. So when you talk about the tear, sometimes, that ACL sometimes it's not completely torn apart. It's just stretched out. My question is, what patient qualifies for this Bears procedure? Is the ligament completely torn and you bring the two ends together, or is it just stretched out? Who qualifies?
That's a perfect question. So we'll talk about the other type of ACL repair as well to help you with that sort of understanding. But basically, the wild part is now, initially I got the MRI, I kind of peek at the ACL, I'm like, that's torn, and that's great. Right? I know it's reconstruction. I know I have the answer. Now I get the MRI. I'm like, oh, geez, is this a repair or is this a reconstruction? And I have to do certain measurements and figure out whether or not they're repairable before I go in there, because half the patients are coming and asking for these surgeries. And I have to either tell them you're a candidate or tell them you're not a candidate. So the patients who are candidates, and again, you got to be careful with new products, because the new product company is going to sell them more aggressively than I am.
Yep.
It's just anything, and you know how this works.
Oh, yeah.
So basically, the way it works is people that have at least a stump of tendon that's more than 2 centimeters are candidates for this potential repair. And so that makes, for people in the audience, they're trying to figure out, well, so half the tears that you have are middle of the ACL or lower, and those are probably not fixable. And there is 30 or 40% where you've got to still, it tears off where the femur attaches. Mm-hmm. And those are the ones that are repairable. And so those are the ones we're looking for on MRI. And again, the problem with this is sometimes I tell patients, and it makes everything a little bit tricky because they're trying to make their decision. But basically, when they go in there, I tell them we might not know if it's fixable till we get in. Does that make sense?
Yeah, it makes total sense.
Yeah, so then we're on the fence sometimes when we go in there, but overall, I'm able to fix most of these if I've told them I think you're a candidate, because I've got experience now that looking at the MRI. And so we go in there and we see the MRI, we see their candidates, and we decide to do this implant. Now, the problem is that the Bayer implant is something very simple. This is not wild. And basically what it is you use repair techniques we already have, and then you slide this implant in. But if you look at the number of video techniques on this, since it came out, it was clinically offered, there's been like 35 different techniques. As a matter of fact, the technique that I published almost 10 months ago or 11 months ago was a modification of the clinical trial. And so like people keep modifying it, and I'm doing 2 or 3 different types of options already since it first came out to try to make this even better. And so the problem is when you give a toy like this to orthopedic surgeons that like to innovate, they're going to keep trying to make it better.
Which is good, right?
It's all good.
Yeah.
And the one thing that patients should understand is like the clinical trial had to do the bare minimum, right? We're doing even newer things, which is why we've seen better results, but you can't say, okay, these are, re-tear rates are equivalent, everything's equivalent, because it's a little bit different when you repair your ACL. But patients have to be okay with taking the risk. And a lot of patients are, because they're usually coming in asking for this. And so, it's one of those things. It's anything with new technology, right? Like we don't know that you're for sure going to be better, but we feel pretty good about it. Are you okay with taking the risk? And then that's their decision.
So that's an excellent explanation, by the way. I mean, what is the upside on this repair using this Bayer's procedure to you as a surgeon, but more importantly to the patient, when we talk about outcomes and return to function, timetable, et cetera, et cetera?
Yeah. So we'll talk about the other type of ACL repair in a minute, but for this type of repair, the benefit of it for me is that obviously patients are happy and they like to have the other option of saving their knee. Mm-hmm. I'd love to obviously save every ACL because the proprioception inside that ACL ligament is saved. Yep. And the thought process is that long-term there's less tunnels and things like that. And so therefore it's going to cause less risk of arthritis. That being said, there's no data to show that. We got to be careful because people come in and asking that all the time. And so that's something that we don't know yet. I think the idea is that like you save your tissue, and that's what a lot of people are like. They just want to save their tissue. And so if they have the option to save their tissue, they almost always choose it.
Right.
The downside of this is there is a higher re-tear rate, at least based off the data. Now, I get behind the scenes information because I do this. So we've seen that likely that re-tear rate's probably going to drop. But what they've found is that, the re-tear rate is a bit higher than a regular ACL reconstruction by a couple percentage points. And so you have to be okay with understanding that if you re-tear there's a chance, if I were to go head to head, there's a slightly higher chance that you could re-tear your ACL, your new Bayer ACL. So people have to be okay with that little bit higher risk. The other thing is they can get a little bit stiffer because initially it's a little bit slower protocol. Now with all your PT ACLs, they probably come in quickly. They start moving right away.
Yeah, absolutely.
Yeah, with this one, it's slower. So you're partial weight bearing. You slow down their range of motion. You don't want to stretch the ACL that you've repaired. Now that's going to change soon because like the new way I'm doing it, I'm actually integrating 2 techniques that you're really tightening up this ligament. So I feel a lot better about letting them move faster, but it's going to be a few more years so that protocol is advanced. Because they obviously don't want to mess with the clinical trial because the last thing you want to do is move people quicker. All of a sudden they get more tears and the company goes out of business.
Yeah, right.
So that would be bad.
Right.
And obviously not good for the surgeons either because, even though I don't push people to do it, if I'm doing it and they're doing poorly, it doesn't look good either.
Right.
So I obviously don't want that. But yeah, we've been happy with the results. And again, it's not for everybody. And that's the one thing to make sure everybody understands. And then the other technique is actually, and the recovery of this is the same. So the recovery of this is about 9 to 10 months. So that's important for people to understand because I think it's the same thing we talked about before. People call an ACL repair when it's really a reconstruction, and they call reconstruction when it's really a repair. And so it's important for everybody to understand that there are different things, and a repair is save the tissue. Reconstruction is redo your tissue with something else. There's actually a newer technique where we use a tightrope. It's actually a proprietary thing. And that's actually what we do is we actually take that ACL that was torn and we can actually tighten it back up with this new cinch thing. And this came out almost the same time that was the clinical evaluation of the Bayer came out. And this repair, I do actually even more frequently than the Bayer. And this gets patients back in half the time. But the negative of this one is the data shows that under 25 years old, you probably shouldn't do it yet. There's still not enough data to show that. With the Bear procedure was approved for 14 and above. And so that's the difference. Also, this is actually better for younger patients, the Bear, and the repair is better for people that are a little bit older. And so that's where it kind of becomes confusing if you get that like 35, 40-year-old.
What is the cinch procedure you just described? What is the clinical name? What do you call that procedure?
So the challenge is not as sexy as the Bear, because really the Bear is not the actual procedure. The Bear is literally just the implant.
The implant.
It's actually just an ACL repair, and people are using this ACL technique I told you about, this cinch thing, and then they're putting the Bear over the top.
Oh,
and so
I see.
it becomes confusing because you're like, which one is the helpful one? And the companies are not big fans of this because obviously it can cloud the results. But again, I care way more about my patients doing well than I do about making a company feel good.
Yeah.
And so, this cinch stitch is basically, we used to do it, and people I've trained with, I actually trained with some of the guys that invented the early ACL repair stuff. We'd kind of go in there, put 2 anchors in and tighten up, and it was fine. But again, that's where I think the results were not as good. This new technique, as soon as I saw it, I was like, I've got to start doing this. And I've done like 25 of these. I actually teach the course.
Wow.
I'm going down every year to teach it. And this has been like insane. I mean, we're talking about 5 months. I actually had one of my podcasts, one of the ones you listened to about ACL repair. I had a patient come in. I want this new tightrope tightening device thing you're talking about. And he came in asking for it. We did it. And 5 months later, he was back to everything.
That's amazing. So just for our listeners real quick, just want to describe this and make sure our listeners understand this. So this is a situation where that ACL ligament's been stretched out and it's loose. I mean, once ligament tissue is stretched beyond normal stretching, it doesn't recoil back. I mean, I'm just trying to set this up, and correct me if I'm not explaining it right. And then you go through and you go in there and you put that cinch in there to kind of make that ligament that's maybe loose, now it's taut and it's going to stabilize again. Is that fair to say?
So that the other repair, so the Bear implants usually for when it's fully torn, and usually those proximal tears, occasionally a mid-substance where it's in the middle, but I've got enough stump that it'll grow back. Okay. The repair, I use it for more versatile things, which is the partial tears like you're talking about. So I've done a couple of kids with partial tears, and they've gone back to everything they wanted to in like 5 months.
Wow.
And those ones where there's a partial tear, they're not better. They're still kind of limping along and they're just not feeling good. Well, here's another option. Also, if it's an acute injury, but they also tore something else, I can back it up with this repair and it's not any damage to the knee. And then there's the patients with that proximal tear, that special tear I told you about, where it's right off the femur. Those are the ones that do really, really well. And so I've done a ton of those. And those people, their ligament's actually pretty good quality, but when you get in there, you can see the ligament. What you're saying is actually the opposite of what happens half the time. When it tears, it pops and it's like a rubber band. It actually coils up. And so it's not actually stretched out. It's actually too tight. And so as you start putting the stitches in it and you start pulling it back, the ligament starts stretching out. It's crazy. And it actually goes all the way back to the wall.
Interesting.
And so it's wild. Because before I started doing this a few years ago, I had no understanding of this. It didn't make any sense to me. I'm like, you get in there, the whole tissue's scarred. This looks terrible. Like, I'm not going to fix this. Or you go in there and say, oh, wow, that looks like. Now I go in there, I'm like, this looks like a good piece of tissue. I can fix this. So my mindset was blown once I started doing this and learning about it, and then started actually doing it with patients. And now that I'm teaching about it, it's a pretty cool concept that we can do it. Now, again, I tell listeners one more time, not everybody's a candidate for this. I'd say 1 out of every 10 to maybe 2 out of every 10 patients are an option. But if you think you might be an option, I had a guy yesterday that came in because he's like, you're the only guy that does the ACL repairs, and he was a perfect candidate. So it worked out that we kind of met each other that way. But yeah, it's important for people to understand that this option does exist, because there are people we can save. And I've been blown away by the results of these.
So these new techniques you're describing right now, repairing the ACL, not, quote, reconstructing the ACL, what the advantages are, obviously, I mean, it sounds like return to play, return to function are pretty good and pretty quick for some patients. You're not using a outside ligament source. You're not changing the anatomy of the femur or the tibia by drilling holes, and they've got a good joint. And then just less disruption and I mean, just more minimally invasive techniques. I mean, is that fair to say?
Yeah. So most of that's good. I don't, obviously we're talking about a pretty complicated topic, so I'm trying to make it as simple for the listeners. So you do have bone tunnels. So I think that's people get confused. So the tunnels you have in the repairs, either the Bear or in the Bear are about 5 millimeters, or 4.5 millimeters. So they're small. The tunnels in an ACL reconstruction are 10 millimeters. So they're double the size.
Got it.
The other thing is the other part that's really important is that the one reason people still do the repair, and I will tell you, when I offer them the bear or the repair, it's like 95% of people want it. So even with the higher re-injury rate, people always want that because they want to save their tissue. So it's a very, people, this is obviously a concept, as you asked me to be on here, that people want to hear about because they're kind of blown away with the idea of actually saving their knee.
Absolutely.
Yeah.
Dr. Garcia, real quick. So just if a patient's not a candidate, when you talk about their tissue, if a patient's not a candidate right now for these procedures you described, and they do need a reconstruction, are you using a hamstring? What's your choice right now?
Oh gosh, now we're going into another.
Well, yeah, I mean it's a podcast. We're just chatting. I mean,
I like the way you roll. So
I'm learning. I'm learning a ton here, man. I'm learning a ton here. So yeah.
I know this is like download right now. So so I actually lean towards. I really like quad.
Yeah.
Honestly, quad is. I actually use that same device for the ACL repair as I do in the quad, and I do an internal brace, which we've talked about before on the show a while ago. But the new technology on quad has advanced the most of all of them. I do a lot of patella tendon too, and I do some hamstring. But hamstring, again, I know there's going to be docs listening. They're not going to like this comment, but hamstring's starting to fall out of favor, especially younger patients under 25. There's a little bit higher re-injury rate, and it's because of the size of the graft.
Yep.
And I use a lot of revision ACLs, and thankfully not too many from my office, which is good. But in general, when you have a high volume, you're going to see patients that need revisions. And so the revision patients that come in and have had hamstrings, they tend to be pretty unhappy with the way their leg feels. It feels a little bit weaker. Not everybody's like this. And so there's that, plus the smaller graft, plus a lot of these are females. As you know, it's almost 2 to 8 times higher. It's a bad combination to do a hamstring on. So very few people I'll do hamstring on now. I'm mostly doing quad and patella tendon. And then above, 35, 40-ish, I'll do cadaver on them. And that's a little bit easier recovery for them. But again, it's all patient dependent. And some patients come in, they're like, I know what I want. I read everything on the internet. And this is what I want. I'm like, that's fine. I'm not going to argue.
Yeah.
And again, that's why I know how to do all of them.
Yeah. I mean, I'm just listening to it. It's just amazing. Like I said, I've been doing this 35 years. And when I broke into this business, I mean, the only option a patient had in the ACL days was a Macintosh procedure. And that was a large incision, a long leg cast for 6-7 months. I mean, it was just amazing. And everybody thought that was advanced technique back then. And now you're talking about a repair versus reconstruction. I mean, patella tendon, hamstring. Now you have a quad tendon. You like the quad tendon when it comes to reconstruction. Is it just because it's stronger and it's easier to have it get stable, or what do you like about the quad tendon?
So it's actually the best of both worlds. So you mentioned two, patella tendon and hamstring. Mm-hmm. So people like the hamstring because it's soft tissue. So it's a little bit easier technically to do. And so that helps. Obviously you want to make it, if a surgery is a little bit easier, but the results are better, you'd want to do the easier surgery. And on top of that, there's less concerns like mismatch you have with patella tendon. And patella tendon has its own risks, as you may know, anterior knee pain.
Yep.
So in my younger patients, I still do patella tendon a lot, except for if their growth plates are open. But when they get a little bit older, and again, older is crazy nowadays, we're talking about like 23, 25 years old, then I lean towards a quad because I don't want to have that anterior knee pain risk. And so the quad's a hybrid. It's a mix of patella tendon where it's a bigger graft. So it's 10 millimeters rather than a 7 or 8 millimeter graft. So it's like a hamstring soft tissue though. And so it reduces the anterior knee pain, but you get a soft tissue graft. So it's kind of the best of both worlds.
Wow. I mean, what I'm hearing as we wrap up here, I mean, this has been a fantastic conversation. I certainly appreciate the time, and I certainly appreciate your expertise and your explanation. Great job. But in today's world, I guess just want to summarize, you have options. I mean, the patient now has options, and in your hands, we're talking about 6 to 7 different options, and you're going to assess the patient's needs. You're going to assess their anatomy, their return to function needs, and you're going to give them, in this toolbox that you now have, this big toolbox, the best option with the best results. I mean, is that fair to say?
100%. And we haven't even talked about the meniscus and cartilage, so I don't want to blow away the podcast right now.
No.
But it's all important. And the answer is, in my office, you get a customized approach, but also what also works best for you. I mean, I'll have 3 patients with the exact same injury and they choose different surgeries.
Yeah.
And so the nice thing is I like doing all of them. They're fun. And I like helping people. So whatever they want, if it's going to work out best, like if it's not going to work for them, I'll tell them, no, I'm not going to do that. And I'm not going to sacrifice success for a patient's desire.
Right.
But outside of that, that's the fun part about my job now. It's kind of like, what do you want? Here are the options.
What's fun about these podcasts and what's fun about talking to physicians like yourself is I'm amazed. You know, like I said, I've been doing this 35 years. I'm an old guy, right? You know, I've been around a little while. And it's really weird. It's almost like the computer. I mean, it's almost every time you open up a book or read an article or something like that, the technology and advancements. And we haven't even talked about some of the things you're doing with biologics and some of the biologic principles that are out there on the horizon, what we're going to see in the next 4 or 5 years. I mean, you know, you talked about cartilage restoration. I mean, it used to be if you had a cartilage defect in your condyle, you were just, that's the way it was. You had to wait for a total knee. Back in the day, you had to wait, right? And now you're doing things. We have to have another podcast. We have to have you on Health Matters again. We'll talk about biologics. We'll talk about cartilage restoration. This is great, being able to talk for 30 minutes. Fantastic conversation. Dr. Garcia, how would our listeners get a hold of you? I bet people that are listening going, I got to talk to this guy. How do they talk to you? How do they find you?
So you can go to the Orthopedic Specialists of Seattle website, but also my main website that has all the bear and the repair and ACL reconstruction options and every video you could possibly imagine in terms of surgical techniques. So you want to go to www.grantgarciamd.com. And that's very simple and easy to look up. But if you just look my name up, it'll be like 15 results, and all of them will be something that will link to something that can help you get an appointment or have questions.
Awesome. That's www.grantgarciamd.com. That's grantgarciamd.com. Thank you for your time. Excellent conversation. I learned a ton. I'm sure our listeners did too. Obviously, again, I say this when I talk to folks like yourself. I mean, boy, you love what you do, don't you?
I love it. Every day I love it.
It's obvious, and that's what we need. That's what everybody needs. We need to wake up. We need to have an aha moment. We need to be passionate about what we do, and obviously that makes for a great gift, and you obviously got a gift. Thank you for your time.